Thank you, Peter, and thank you to our panel. What a, just a nice way to end that panel, thinking about how do we not just finance health better, but how do we make those experiences trustful and delightful? And when was the last time that you had a healthcare interaction that was with a provider that you trusted, but also that the experience was delightful? And I think that that is just something that we really should be trying to strive for. So we're going to be switching a little bit, and I would like to bring on Dr. Sarah Stanton. She is also a workshop planning committee member and the Health Equity and Social Justice Endowed Professor and Director of Center for Innovative Care and Aging at the Johns Hopkins School of Nursing, holding a joint appointment in the Department of Health Policy and Management at the Hopkins Bloomberg School of Public Health. She will be introducing our Innovation Spotlight, and we are really excited to bring her on and excited to have you introduce our Spotlight speaker for today.
Thank you so much. And I just wanted to add to the last panel that part of the way of making something delightful is asking about what matters to people. I don't think I heard that's part of engagement and trust is what matters to people, not just what's the matter. So as Dr. Davis mentioned, throughout the sectors of the US health system, person-oriented approaches are critical, especially when considering transformative action. These spotlights provide an illustration of the actual experience on the ground. Dr. Fasih Hameed is the Associate Medical Director for Wellness at Petaluma Health Center, a community health center in Petaluma, California, that provides a whole person approach to keeping individuals healthy via a comprehensive, team-based, and patient-centered primary care system. He will provide us a brief presentation on the innovative person-centered strategies in use by their health center.
On me?
Yeah, go ahead.
All right. Let me start my timer. Greetings and thank you to the Planning Committee. I'm honored to be here to share a bit of our vision and practice of whole person care at the Petaluma Health Center and FQHC in Northern California. For more than 10 years, we've been innovating, brainstorming, trialing, and failing, but mostly trying to live up to this motto, the center of good health. But what is good health, you may ask, and what is good medicine that can get us there? Well, over the next 10 minutes, we'll summarize 10 plus years of hard work as we attempt to answer these questions. But first, I have to start with a painful elephant in the room moment. This is, maybe we already know this, but we all want whole person health. That's why we're here. But the current system, as we've been talking about in the last panel, is really more of a partial patient payer model. It's neither wholesome nor healthy. It's partial because it chains us with embedded inequities and treats some but denies others and divides people into organ systems and squeezes suffering into tidy DSM and E&M boxes. And it's also partial, not as only in part, but because it's biased towards intervention and specialist care and expensive procedures, and biased by the industries and pharmaceutical and payers. And as a result, as you know, we have this very expensive and very ineffective healthcare system. So I thank you for being here and thank you for trying to make this better. Slide. So that awkward moment behind us, let's dive into our model of good medicine at Petaluma Health Center. Here are a couple of triangles. The one on the left is probably familiar to you. That's the triple aim. It's a nice, simple vision for good medicine, and we'll keep it in mind. And we keep it in mind as we do our work at Petaluma Health Center. On the other side, we have a less familiar model. It's borrowed from naturopathic medicine. It's called the therapeutic order. This encourages prevention and self-care, and going up the pyramid increases invasiveness, risk, and cost. But obviously, like, you sometimes need surgery and you sometimes need medicine, but remembering that there's other stuff below that. Slide. So a few more familiar concepts here. On the left, the determinants of health, but they're different than the social determinants of health. Show us maybe 10% is healthcare, 40% behavior. So I've elaborated on those behaviors in this tree from when I was very early clinician, developed this lifestyle model, which shows that, like, these things that are in the roots are the things that make the tree healthy. So we can't just prune the diseased branches anymore and expect the tree to get better. We really have to work on those roots. And in the middle, we have the social determinants of health, with which you're all familiar. And just highlighting that 50% is linked to zip code. And we'll be exploring that. Slide. So just adding these all up, we have here an example of what our good medicine pyramid might look like. Incorporating the wisdom of all these models and some other stuff. I could title the slide, Out of the Box and Into the Pyramid. So the base here is community wellness and equity work. It all builds on this. It's the foundation. A well community makes well people. Maybe zip code medicine is going to be the next medical subspecialty. Above that, I separated food out and nutrition security out from the other social determinants of health because I think it's somewhat low-hanging fruit because of the money and the impact of the value that we could have. Imagine what an overhaul of school lunches, for example, might do for our collective health. So moving up, a couple other things. I've bolded prevention. And the last panel was really inspiring because I agree completely that this line of promotores, community health workers, case managers, patient navigators on that self-care and education piece, they're the unsung heroes of whole person care. They're the ones on our team who are really making the magic happen out there. They're connecting the dots and catching those who fall through the safety net. Above that is mental health care, but really it's kind of everywhere. I think it should be kind of sort of infused throughout the entire pyramid. And above that, we use a lot of wellness providers at our clinic. Those are things like acupuncturists and chiropractors, physical therapists and yoga therapists that address trauma and pain and the way that it lies physically in the body. And above that, primary care, I think historically it went like kind of up from that. Primary care was medications, and then you refer, and then you have invasive procedures, et cetera. But I think that sort of the whole person primary care, like we practice at PHC, kind of goes all the way to the bottom of the pyramid. And the rainbow represents the vibrancy of our collective diversity when we all shine our brightest and healthiest. So that's the model. That's our philosophy, our dream. Now let's explore how we actually make this happen at PHC. Slide. So in 2009, we were actually building a physical new health center, and we wanted to promote a different model of care. We knew that. So we built into the structure space for team-based care, groups, a kitchen, healing colors, and art. And we listened to our stakeholders, our community, our patients. And recognizing the importance of these upstream factors, we were early adopters of addressing ACEs and screening for ACEs and social determinants of health using things like the Purple Binder and Big Bertha. And we do active population management, recalls, and care gap alerts. As a result, we consistently achieve scores of nearly 100% on our QIP and top tier on our UDS measures. So we provide objectively high quality care. Slide. Getting even more granular, on the next few slides, I've highlighted sort of 4 main categories of whole person, social determinants, and good medicine in our approach. Since this conference is about financing, I've bolded anything on these slides that we can get paid for reliably in our PPS model, and then starred anything that's a little bit weird, and then everything else is sort of free. So food, it's so big. It's the low-hanging fruit, but it's not just about food security, it's nutrition security. Our nutritionists educate, and we rely on community partners. We're very blessed to have a lot of community partners who can help us provide our patients with high-quality, nourishing foods. In addition, we took a patch of our greenbelt, industrial greenbelt, and a 4,000 square foot patch, and we converted it into a thriving food forest, complete with a paid intern and a rotating crew of volunteers. And in our lobby, we have a seasonal pharmacy. In addition to the pharmacy, which provides medications, we have a pharmacy which provides fruits and vegetables, organically and locally grown, with sliding scale prices that beat most supermarkets, plus it accepts EBT and the SNAP benefits. Our industrial level demo kitchen hosts virtual and in-person health and cooking demos so people can relearn how to cook for health. Slide. This is a huge part, and this is where the case managers, navigators, and certified enrollment counselors work with the homeless, disabled, and most impoverished patients to help them meet their basic needs. And as you can see, most of this stuff is unfunded. We do have a homeless clinic, a school-based health center to try to meet patients where they are. Slide. So recognizing the critical importance of justice and DEI work, it's the base of the pyramid. We still have a long way to go to bridge the equity gap and address all the levels of embedded racism, but we have started with a weekly committee and a paid consultant to try to do this hard work and share it with our providers and our patients and staff. Addressing loneliness and trauma. Vivek Murthy, the Surgeon General, talks a lot about loneliness. Dr. Jeff Geller, one of my mentors, Nadine Burke-Harris talks about ACEs. We do as much as we can around this work. And a lot of it started really around chronic pain years ago. We developed groups in acupuncture to help patients reduce dangerous medications. And it was common for patients after coming to a group and learning about opioid-induced hyperalgesia, surrounded by peer support and testimonials, to self-wean opioids as they embrace these like alternative methods that we were giving them that are described in the HHS pain strategy for the nation. The pandemic underscored our prior efficacy. After 6 weeks without acupuncture, chiro, or groups, dangerous opioid prescribing, which had plummeted before the pandemic, had increased by 20+% at our clinic. What are integrative medicine consults? They're like the ultimate whole person tune-up. You spend an hour with one patient, bill a 99214. Sure, it's kind of crazy. It doesn't make any financial sense for an FQHC, but these long visits are essential for untangling the web of our most complex patients and empowering real progress. Good medicine takes time. Slide. And when patients said, oh, I can't afford to exercise, we just built an exercise room and gave the exercise away for free. Slide. So that was our model of good medicine. Was it sustainable? Maybe. But in the partial patient payer model, the only way to fund all that whole person care was to see lots of visits. And we did. But seeing like upwards of 13 patients, super complex, never felt very sustainable, especially when you're being onslaught with electronic messages at the same time. So the dark side of fee-for-service is provider burnout, which we are seeing a lot of these days, of course. Compassion training is only a stopgap. We are the proverbial blood from the stone. But nonetheless, we were proud of our model. And then COVID came and pretty much blew it up. And as we pivoted to confront the pandemic, frontline, and the devastation in its wake, we learned many things. By conservative JAMA estimates in 2020, the national death rate was 20% over average, with 75% of that attributable to COVID. But it was worse in vulnerable communities like ours, which rely heavily on the comprehensive services of community health centers. Telehealth was essential, but it's not enough. In 2020, our death rate went up 30%, and only half of that was COVID. As patients come flooding back now, our providers are overwhelmed. Peds, obesity, and mental health crises, and new chronic pain are thriving in this isolation. Group shared medical visits were one of our ways. They were highly effective, generating community wellness, peer support, and self-empowerment while reducing overall healthcare costs. Yet there's no official government billing policy for groups, only letters from CMS and some innovation orgs, and it remains confusing gray muddy water. I hope a new billing model could help with that. So in summary, comprehensive, whole person, good medicine really matters. But the fee-for-service partial payment patient model is neither sustainable nor effective and sends the wrong message. If we care about these things, if we care about people, value people, we will shift the funding to align with these values. We spent a long time trying to get blood from the stones of an antiquated model. Maybe it's time we use those stones to build a new foundation of good medicine. I thank you for listening. I thank you for being here. I thank you for your work.
Thank you so much, Dr. Hameed. That was just a great summary of really how we are striving to provide that excellent care and how our payment system often gets in the way of that. So thank you for the work that you and the folks at Petaluma have been doing. It's really great to hear about that.